Alright, it's time to talk heart and vascular system inside the thorax. This is the big money talk, and let's get going. So here, in case anyone has missed this little fact so far, the heart is actually a muscular pump sitting inside your thorax, and it's going to operate two circuits simultaneously. The pulmonary going to the lungs, and the systemic circuit going to the rest of the body. So right here we've got the heart inside the fibrous outer coating that it has, the pericardium. So we remove that. We can see the heart in context with the other organs. Let's go a step further and just remove everything but the heart. So first up, the pulmonary circuit is the circuit in which we're going to have poorly oxygenated blood from the rest of the body coming into the heart from the vena cava and getting to the lungs so that it can be reoxygenated. So the inferior vena cava is bringing blood in from the abdomen, pelvis, lower limbs, no surprise there. And the superior vena cava is bringing it from the head, the thorax, and the upper limbs. So they're going together and draining to a common chamber in the heart. This is the right atrium. It's worth noting that blood from the heart itself, once it's been deoxygenated, comes to the right atrium also. And it's going to pass into the next chamber, the right ventricle, through the right atrioventricular or tricuspid, because there's three cusps to this valve. The right atrioventricular valve into the right ventricle. Lots of musculature hanging out in here. We have some muscles holding onto these valves, more on them in a bit. And then, when this pumps, it's going to head up towards the outflow tract. And in this case, there's a smooth area right here. That's the pulmonary trunk. The blood's going to pass through three pulmonary semilunar valves, which prevent regurgitation, as does the AV valve. It's preventing blood from going backwards. And from there, it's going to pass into the right and left pulmonary arteries to go to the right and left lungs. Coming back, we have now got the systemic circuit starting. We have oxygenated blood returning from the lungs through pulmonary veins. So they're coming in to the left atrium of the heart right there, passing through the left atrioventricular or bicuspid valve, also called the mitral valve. All words for the same thing. And here it enters the left ventricle. And just take a second and look at the thickness of the left ventricle compared to the thickness of the right ventricle. Right ventricle had to pump to the lungs, which are pretty much side by side with the heart, whereas the left ventricle has to pump through the rest of the body. So it's a much thicker wall lining that chamber, although the volume inside the left ventricle is roughly equivalent to the volume inside the right ventricle. So from the left ventricle, it's going to pump up into the smooth outflow area of the aorta here, passing through the three aortic semilunar valves and up into the ascending aorta, after which it's going to distribute through the brachiocephalic trunk, the left common carotid, the left subclavian, and then into the descending aorta from there. So if we look at the heart in place as it sits inside the chest, it has a right border, which we're going to notice on X-ray, and making up that right border are the two vena cavae, superior and inferior, and the right atrium. And if the right atrium balloons out, it can be seen on an AP or PA radiograph. The inferior border is primarily the right ventricle. The way the heart sits in the chest, the right ventricle is actually tilted a bit inferiorly, and the left border is mostly the left ventricle with a tiny bit of the left auricle right here. The auricle on the left and the auricle on the right are just these little dog flap ears, and that's what auricle means, ear. These little flaps sticking off the left and right atria respectively. Now the superior border is very tough to distinguish on an X-ray, but that's going to be formed by a little bit of a radiopaque outline showing us basically where the left atrium and right atrium are located. So these are the borders of the heart that we're going to see on radiographs more often than not. And next up, we have the muscle. Now let's take a look inside the right atrium, and right here there's a landmark called the fossa ovalis. It's a little thin area just inside the wall between the right atrium and the left atrium. It's not doing much right now, but embryologically it allowed blood to bypass the right side of the heart, the pulmonary circuit, and get straight to the systemic circuit coming from our placenta and the inferior vena cava. We'll talk a little more about that when we talk about heart development, but just note that thin area is present there, and if people have a patent foramen ovale, that's where it's going to be. Superior vena cava is bringing blood in from the upper limbs, head, and torso. Inferior vena cava from the abdominal pelvic organs, the lower limbs, etc. And inside the wall of the right atrium we have what are called pectinate muscles. Now there's a smooth area, which you can see right here, Then we have the pectinate muscles. So a little bit of a distinction in there. The pectinate muscles are very prominent in the auricle, but not so much in the rest of the atrium. So there's the right auricle. And note here we have what's called the ostium of the coronary sinus. This is where blood from the heart itself enters the right atrium. And a smooth kind of ridge runs between the pectinate muscle and the smooth remainder of the right atrium. That's called the crista terminalis, and it doesn't look like much, but it's where we find the pacemaker cells of our SA node. More on that in a little bit. Inside the right ventricle, we've got a large strut of kind of a heart muscle going from the septum between the right and left ventricles over to the right ventricular wall. This is called the moderator band, also called the trabeculae carneae, which I particularly like because it translates as strut of meat, but that's a muscle that actually also allows depolarization to speed through the ventricle to get to certain parts and coordinate the contraction in a apex up sort of a manner. Now we have papillary muscles inside the ventricles, pectinate muscles in the atrium, papillary muscles in the ventricle, and we have some really tiny little nubs here, the cepillary papillary muscles going to the septal folds of the right atrioventricular valve. Then we have the posterior papillary muscle connected to the chordae tendineae, which are these little basically threads. The chordae tendineae connect these muscles to the valve folds right there. Then we have a nice big anterior papillary muscle here. Notice it's duplicated. That does happen. And again, chordae tendineae going up to the valves of the atrioventricular valve there. Its leaflets right in there. The semilunar valves look much different than the atrioventricular valves. These guys are kind of parachute looking, whereas these are more just kind of half-moon folds that come together on the midline and seal off the area above from the area below after the heartbeat has gone through its systolic phase. So right there we have the anterior, posterior, and septal atrioventricular valves. And don't worry too much about identifying them because it's really easy. The anterior ones are anterior, posterior are posterior, septal are just near the atrioventricular septum. Now let's take a look at the left atrium with pretty much everything removed except for a few key landmarks. Here's that fossa ovalis, same thing. It's that little thin spot that used to connect the right and left atria. There's our left auricle full of pectinate muscle. And the bicuspid valve or mitral valve has been removed, aka the left atrioventricular valve. And now we'll put that stuff back into place and see the left ventricle itself. We only have two valves, hence bicuspid, so we have a posterior and anterior atrioventricular valve. The anterior one in this picture has been obscured, and likewise we have anterior and posterior papillary muscles giving off chordae tendineae to each flap. One thing to know is that we don't have exclusively anterior papillary muscles and chordae tendineae exclusively to the anterior valve. They actually are shared by both valves, which is kind of nice in that if you have damage to one of these, your valve doesn't just kind of start flapping in the breeze spontaneously. Here's the aortic semilunar valves, and they look pretty much exactly the same as the pulmonary ones with a couple key differences. Chordae tendineae anchoring the atrioventricular valve there. Here's the aortic semilunar valves, and they have these little nubs that help them meet on the midline, and on two of them there's some little holes or ostia. These are actually where our coronary arteries come from. We have two coronary arteries, the right and left coronary artery, and they're coming from these ostia here. So as the heart beats, the blood rushes out through the arch of the aorta, then the ventricle relaxes and the blood tries to rush right back in. It just tries to fill that space that's opening because it goes where pressure tells it. These flaps, these aortic semilunar valves, open up, catch the blood, and it's going to then just push itself into these ostia for the coronary arteries. All right, so take a moment, pause, and come back when you're ready to answer. I forgot to put an arrow up here. Fossa ovalis. The answer is B. Fossa ovalis is shared by the right and left atria. Now let's take a look at the inside of the heart a little more. Particularly, there's three layers. Now, the epicardium is the area on the outside. Epi means above. The myocardium is the muscle of the heart, and it's pretty much everything we see right in here. And the endocardium is the lining on the inside of the heart. And this picture gives us a nice view of just how thick that left ventricular wall is relative to the right ventricle. And they share the ventricular septum just there on their midline. So let's talk epicardium, myocardium, and endocardium right there on the inside. Epicardium has an outside lining of flat squamous epithelial cells that secrete a little bit of fluid. The epicardium has that serous layer there that's going to release fluid that smooths the movements of the heart inside the pericardial sac. Deep to it we have some fat and connective tissue, and we often have quite a few blood vessels and nerves traveling through this layer as well. So it's allowing things to move around the surface of the heart. So there's the serous lining, adipose, and a few bit of blood vessels here. The blood vessels will actually jump into the myocardium as well, so that's what we're seeing happening right here. The myocardium itself is the majority of the heart, and it's really the functional core of the heart that we care about. These muscle cells, and they are true muscle cells, are a lot like skeletal muscle in many ways. They're striated, and they're striated because they have actin and myosin molecules that are sliding over each other just like skeletal muscle to cause the contraction. However, these heart myocytes, cardiac myocytes, are branched. You can see this one branching right here, and they're connected to each other end to end by these intercalated discs. Now they actually attach along their length as well, but that's not as visible. But these intercalated discs actually allow a little bit of fusion of these muscles so that one contracts, it pulls its neighbor along, and they also have gap junctions within them that allow the cytoplasm to be shared between cells. And what that means in this case is that it's going to pass its depolarization down to its neighbors, and it just kind of depolarizes in a nice wave, and contraction happens in a fluid manner, kind of like watching people do the wave at a big stadium game. One other thing to note, skeletal muscle has nuclei peripherally. Cardiac myocytes have their nuclei centrally, actually within the cell. And then lastly, the endocardium is basically the lining on the inside of the heart, and it's continuous with the lining of the vessels called endothelium. So this endocardium, its big job is to not allow clots to form. Endocardium and endothelium are very good at preventing clot formation. They're not perfect at it, but they tend to help the blood not coagulate in place and cause thrombi. The atrioventricular valves and the chordae tendineae are an extension of the endocardium, and in particular the connective tissue layer that's just deep to its simple squamous lining. So now let's take a look at the conducting system of the heart, the electrical depolarizations that move through the heart and allow it to contract in a coordinated way. So the sinoatrial, or SA node, is right here in the crista terminalis of the right atrium. That's going to spread depolarizations across the atria. So the cardiac myocytes will pass the depolarization from neighbor to neighbor and contract all the way from the right to the left atria. And we're going to have the AV node, the atrioventricular node, located right here at the space between the atria and the ventricles. It will then pass that depolarization through a specific and singular bundle into the ventricular septum. Now at that point, we're going to have right and left bundle branches made up of specific fibers called Purkinje fibers. Those are cardiac myocytes, but they're special in that they have a lot more glycogen in their cytoplasm, which makes them a lot more quick to conduct the depolarization. It's a little less contractile, but they speed the depolarization down towards the apex of the heart. So instead of pushing the contraction from the base to the apex, which would be not really terribly advantageous in terms of fluid mechanics, it speeds the depolarization down here to the apex and adjoining area of the ventricular wall, so the contraction happens from apex up to push blood into the aorta and the pulmonary trunk. So we have right and left bundle branches traveling down the septum. From there, we're going to go into the right and left ventricles and spread out there, and that's what allows the heart to kind of wring blood out into the large vessels. Now, you might be wondering why that bundle of His and the AV node are the only places we have depolarization pass from the atria to the ventricles, since it can pass from adjacent cardiac myocyte to adjacent cardiac myocyte. The reason is we have what's called a fibrous skeleton of the heart, which is a bunch of dense connective tissue that electrically isolates the atria from the ventricles. So it acts like a big resistor. So if we take this away, that fibrous skeleton forms the base for the leaflets and the valves of the heart, but it has a little gap right here in the middle for the bundle of His, and it actually acts as an insulator. So the only way that we should be getting electrical depolarization from the atria to the ventricles is through that little tiny hole right there. Now, during systole, we have contraction of the ventricles. We don't want backflow of blood into the atria, so the anterior and posterior bicuspid valves are going to close. The anterior, posterior, and septal valves of the right tricuspid will close, but since the ventricles are pumping, the aortic and pulmonary semilunar valves are wide open. If we have the opposite happening during diastole, contraction of the atria, relaxation of the ventricles, we have the atrioventricular valves open and we have closure of the semilunar valves. Now, normally I would not ask you to name these valves. That would be kind of a bit of minutia, but something actually interesting works out here. If we have the acronym LARP, that will always help you remember which valve is which. So if you look at the pulmonary semilunar valves, P is for pulmonary, so we just need the LAR. And look right there, left, anterior, right, pulmonary, LARP. Then over here for the aorta, we've got aortic, there's the A, so LARP, left, right, posterior, semilunar valves. So that comes in helpful to you later in life. Congratulations, happy to help. Right here, I want you to notice that on the left and right aortic semilunar valves, we've got the ostium for the coronary arteries. So the right coronary artery here, and the left coronary artery here. Whoops, jumping ahead. So right here, just keep in mind that these valves opening and closing can cause typical sounds as they open and close and the heart contracts, and you can also have clicks, you can have murmurs if these valves have any sort of an issue with them. You can't really put a stethoscope right over them, and having sound conduction through the sternum doesn't work out quite so well, so you just want to know that there's certain areas where you'll place the bell of your stethoscope to find the most prominent heart sounds. So right here, aortic semilunar valve, if you want to try to auscultate that, you're going to aim for your second intercostal space or next to the sternum, so right around here for your aortic semilunar valves. Pulmonary semilunar valves, you're going to just skip over to the left side, so right there is where you'll be able to hear that best. It's not necessarily where it's located, but it's where you'll hear it best. Tricuspid valve, actually on the left fifth intercostal space near the sternum, and then bicuspid valve over here towards the mid-axillary line. So just be aware that those are the places you're going to try auscultating those valves. So let's talk about things that can go wrong. What's going to go on with the heart? Well, one of the biggies is the coronary arteries that we've already discussed can become blocked. So let's talk about their anatomy. So right here, we have the right coronary artery coming off the ascending aorta. It's going to go around the space between the right atrium and the right ventricle, and shadowed in here is the posterior side of the heart. It's coming around that way. So there's the right coronary artery. It gives off, typically, a nodal branch, and that's going to be the blood supply to the SA node. So pretty important branch, and if that gets blocked, you can wind up with some pretty typical arrhythmias or difficulty of the heart to contract in a rhythmic, controlled manner. So 60% of the time it comes off the right coronary artery, so keep an eye out for it there. As it approaches the margin of the heart, it gives off a right marginal branch, and if you're looking at this on an x-ray, that branch will more or less outline the right margin of the heart. There's some ventricular branches over here as well. On the posterior side, we have a posterior right ventricular branch, and finally the posterior interventricular branch, supplying the interventricular septum on the posterior side of the heart. Over here, we have the bigger left coronary artery coming off the ascending aorta there. So it's there. It gives off two large branches once it kind of peeks out from behind the pulmonary trunk. we have the anterior interventricular artery, which you will almost certainly hear referred to as the LAD, the left anterior descending artery. So just know those are the two same things. It's going to give off a left marginal branch and several diagonal branches that are taking care of the ventricular musculature nearby. There's also going to be some perforating septal branches right there. And the other branch of the left coronary artery rolls around between the left atrium and the left ventricle to go to the posterior side of the heart. That's the circumflex branch of the left coronary artery, and it's going to give off, typically, some posterior left ventricular branches. Now, most of the time, 85% of the time or so, our posterior interventricular artery comes off the right coronary artery, and that makes it a right dominant heart. So a right or left dominant heart is determined by which artery is the parent artery for the posterior interventricular. So here's a right dominant heart, but in a left dominant heart, in addition to that posterior left ventricular branch, the circumflex branch of the left coronary artery keeps going and supplies that posterior interventricular side and vessel there. And that's going to be a major consideration if you're having to do any kind of stenting or having to do anything that is involving a bypass graft in this area. So you need to know what the flow is before you go in and actually make some interventions in the area. So that's the arteries. Now let's talk the veins. There are veins that accompany the arteries, but they don't share the same name. All of them, more or less, want to wind up here, the coronary sinus. And this coronary sinus is what dumps blood from the heart into the right atrium at that coronary ostium. So right there. So small cardiac veins tend to parallel the right marginal artery. Get a little gathering from here as well, and come around and then dump into the coronary sinus right here, very close to where it dumps into the right atrium. The middle cardiac vein parallels the posterior interventricular artery and also joins the coronary sinus very close to where it goes into the right atrium. On the anterior side of the heart, we have the anterior interventricular artery paralleled by the great cardiac vein, and it's got multiple tributaries coming in and forming the rest of the coronary sinus here. There's no clear division point for when the great cardiac vein stops and coronary sinus begins on these pictures, so I won't ask you to distinguish them in terms of here versus here and so on. But great cardiac vein definitely present here on the anterior surface of the heart. The right atrium actually has some small veins, they're not shown in this picture, that literally just open into the right atrium. So there'll be some small veins that just go from the muscles straight into the right atrium and don't bother going through a roundabout method of getting to the coronary sinus, they just go straight in. Alright, so let's take a moment, do some quick questions. Take a moment, pause it if you need to. Alright, so what are the leaflets that contribute to the left atrioventricular or bicuspid valve? Well, it's bicuspid, so it can't be B or C or D, so we're left with A, and that's it. Anterior and posterior leaflets of the bicuspid valve. Next step, go ahead and pause. And coming back, he has a left dominant heart, and that's what determines the blood source for the posterior ventricular artery. So we have to start with the left coronary artery. So right coronary artery is out, E and F are gone. A and B start with the coronary sinus. That's going towards the veins. So we're left with C and D, and to get there, we're going to have it follow the circumflex branch all the way to the posterior interventricular artery. So D is the correct answer here. Now, let's talk vessels. We've got many vessels going all over the body. We've seen a lot of them in the limbs, back, and head and neck, but let's just do a quick run through of the biggest. The ascending aorta gives off coronary arteries to the heart. Arch of the aorta gives off the brachiocephalic trunk, which is going to give off the right common carotid artery, supplying head and neck. Right subclavian artery, supplying the right upper limb, part of the neck as well. Then, off the arch of the aorta, we have a separate left common carotid artery to the left head and neck, left subclavian artery to the left upper limb and neck, and now we're going to enter a little bit of unknown territory for the rest of this course. As the aorta descends, it's going to give off intercostal branches in the thorax and lumbar segmental arteries or lumbar branches in the abdomen. They're going to supply the body wall. Gives off several unpaired branches inside the abdomen. Little preview coming up for the next section. We have the celiac trunk, which supplies the foregut, the superior mesenteric artery supplying the midgut, and inferior mesenteric artery supplying the hindgut. If you don't know what any of that means, don't worry. We're going to get there in the next segment of the course, but we're planting that seed right now. We have some paired branches going to things like the kidneys. The renal arteries supply the kidneys. The gonadal arteries are supplying the testes or the ovaries, depending on the sex of the person involved. Then we're going to have common iliac arteries, and they split into an internal iliac artery, which is going to handle the muscles of the pelvis through its posterior branches, and the pelvic organs, or the pelvic viscera, through its anterior branches. Then the external iliac artery, last but not least, is going to give off the femoral artery and therefore supply pretty much the entirety of the lower limb. Now, inside blood vessels, just like the heart had 3 layers, we have 3 layers of the vessels, and they actually are fairly well matched. So here we have an artery on the left, a representative vein on the right. We have the tunica intima, and that's very much like the endocardium of the heart. It's going to be endothelium, meaning a single flat squamous cell layer with some connective tissue resting underneath it. The tunica media tends to be largely muscle, but instead of cardiac muscle, we have a lot of smooth muscle, along with some elastic fibers in the more prominent vessels, the ones that are really huge and have to accommodate big changes in pressure with each heartbeat. And then on the outside, we have the tunica adventitia. This is basically connective tissue. It's irregular and has some fibers that link it and anchor it to the nearby surrounding structures. So the tunica adventitia keeps us anchored. It's also worth noting that that's how the blood vessels and nerves to the vessels themselves get there. Blood vessels need their own blood supply. It's called vasa vasorum, and we'll see a little bit more of that as we go. The vasa vasorum right there, it supplies the tissues of the vessel, and there's even some nerves that are going to be innervating called nervi vasorum. So what can go wrong? Well, some of the more prominent things, you can have arteriosclerosis. Now that's going to be caused by cholesterol or fatty deposits that wind up in the tunica intima and media. Now those by themselves aren't terribly damaging. The problem is macrophages in the area try to get rid of the fat deposition inside the vessels, and they start causing inflammatory activity, releasing cytokines, and it winds up damaging the vessel and making calcifications happen in the wall, causing overgrowth of connective tissue and smooth muscle, and all of that disruption of the endothelium, or the tunica intima in this case, can result in clots or thrombi forming within the vessel. So here we can see an aorta, nice and rubbery. This is a healthy aorta, and here's an arteriosclerotic aorta, kind of showing the same area but in an arteriosclerotic specimen. Just so you guys know, atherosclerosis is referring to sclerosis of any vessel, and arteriosclerosis is specifically that affecting arteries. So just be aware of that. Other things that can go wrong involving vessels, one would be restenosis, and in this case it often follows a placement of a stent, which will have overproliferation of the smooth muscle in the tunica media. So in this case we have a stent that's present here, and somehow it aggravated or irritated the underlying tunica media, and we have overgrowth of smooth muscle into the lumen, which you can see now is even more compressed than it probably was beforehand. Another issue that can come up is when we have weakening of vessels, we can have aneurysms. So this tends to happen when the tunica media can no longer handle the pressures it's being exposed to, and it winds up ballooning out. So again, aneurysms are going to be a result of weakening of the vessel, and to weaken, the vessel pretty much has to have its tunica media become the weak link and balloon outward. So aneurysms are no joke because arterial pressure is pretty significant. Here we can see an abdominal aortic aneurysm, and here's one that actually burst. You'll often actually have that ballooning out happen in advance, and we'll actually wind up with a pulsatile mass inside the abdomen that can sometimes be palpated from the front. They can also dissect, meaning this wall of the vessel can split, but the blood can spread underneath the tunica adventitia along the vessel itself. Now, at the smallest layer, we have some structures that are neither arteries or veins. Arteries become muscular arteries, become arterioles, and eventually they become capillaries. Capillaries only allow 1 or 2 red blood cells to pass through them at any given moment. There's not much in the way of tunica media or adventitia that's visible, and we can just see this little signet ring appearance here of this thin cell cytoplasm of the endothelial cell lining it, and its nucleus right here. Here we have one with 2 cells kind of next to each other forming this vessel. So this is where the thinness of the wall allows gas exchange to occur between the red blood cells within the vessel and the tissues and cells outside of the vessel. Most of the capillaries in our body are what are called continuous capillaries, or capillaries that just have an unbroken appearance here. They have a complete basal lamina on the outside. Their cells meet their neighbors and form very tight seals with each other. And most of the places in the body, this is what we see. These are the majority of the capillaries throughout the body. But some places we have what are called fenestrated capillaries. In this case, we still have a complete basal lamina outside of these cells, but the cells themselves have holes or windows, or in Italian, fenestrae, within them that allows fluid to leave the blood very quickly, so we can have fluid pour out of the vessels into the surrounding tissues. This tends to happen in places where we have a lot of filtration happen, so inside the GI tract in places, but also where we're forming CSF in the choroid plexus, ciliary body, where we're forming the fluid that surrounds our eye, the aqueous humor. Renal capillaries, we want a lot of fluid leaving to get into the filtration apparatus for our kidneys, and so forth. So you can see this electron micrograph showing the numerous holes or fenestrae, windows within the cell. And to take it one step further, there are also what are called discontinuous or sinusoidal capillaries. These have huge gaps between adjacent cells, as well as big openings, large fenestrae in the cells themselves, and no basal lamina. Essentially, the blood, plasma, as well as even just some of the cells can occasionally just spill out of these holes, and this is going to be places where you have a large amount of screening going on. So the liver, the spleen, the bone marrow, these are the places you find these sinusoidal capillaries. Now, capillaries become fused to each other to form small venules, which get bigger, become muscular venules, and they more or less accompany the arteries of the same size, but they look a little different. Their tunica media is much thinner, so they don't form nice little round circles or ovals. They tend to be a little bit more strangely shaped in appearance. Inside these vessels, we have the majority of our blood at any given time. Because the vessels don't have the heart pumping them directly, veins have already gone through a capillary bed, so we don't have the heart propelling blood through there. They tend to hold most of the body's blood at any given time. It takes muscular contraction as well as working against gravity to push the blood up through the veins towards the heart, especially from the lower limbs where it has to fight gravity. One thing that helps in this case, is valves. We actually have valves in the wall of many of our veins that prevent retrograde blood flow. So right here, we have blood in a vein. It gets pushed past the valves here and here, and when the blood tries to rush backward, these valves will hopefully close. So these valves are just continuations of the tunica intima out into the lumen, but they prevent retrograde blood flow, or so we hope. So that retrograde blood flow can become a problem if the valves are insufficient, or if they've got too much blood in them, or they just kind of are unable to do the job, and we can wind up with varicose veins. So in this case, we have veins that have blood kind of pooling in them, and it can actually sometimes even thrombose, kind of clot, within those veins, and it's largely due to valvular insufficiency or weird connections between deeper veins and the superficial veins of the lower and upper limbs. So varicose veins right there. A more pressing problem is going to be deep venous thromboses. So if we have a situation where someone is unable to move for a while, because there's so much blood in the veins at any given time, and if the blood doesn't get propelled towards the heart, it tends to get static, and static blood tends to clot. And so someone who's on an international air flight, an international airplane trip, and winds up sitting still for an extended period of time, or people who are post-surgery and can't move, they tend to have blood get static in their veins, and that blood can clot and form a deep venous thrombosis. That can cause edema. So you can see here this person has their left limb grossly swollen, probably because their femoral vein or external iliac vein has a big clot in it that won't allow blood to bypass it. And you can compare that to the right side here, which seems to have pretty unimpeded blood flow going back up those veins. If that thrombus breaks loose, we can wind up with a pulmonary embolism. An embolism is a thrombus that's broken loose, and it'll basically travel until it encounters a capillary bed or vessel that's smaller than it is. Now, this is tough to see, but this is what's known as a saddle embolus, and this is bad. The fact that this is a pathological specimen tells you that this person did not survive. This embolus likely traveled from their lower limbs, broke loose, and went through the external iliac vein, common iliac vein, inferior vena cava to the right atrium. Right atrium passed it to the right ventricle pumped it into the pulmonary artery, and at this point it split and formed, it kind of straddled the right and left pulmonary arteries, blocking blood flow to both lungs, and without blood flow to the lungs, we can't exchange oxygen, and that's why this person passed away. So often smaller seed emboli will go to the lungs first and kind of give someone a warning that there's a blood clot ready to break loose. But they are life-threatening, and it's one reason we keep compression garments on people who are going to be static for a long time or post-surgical, because narrower vessels, veins under compression, have faster flow through them and don't tend to have as much likelihood of forming these thromboses that can break loose and become emboli. Now let's talk about the pericardium, something we haven't spent a lot of time on yet. The pericardium is the fibrous outer layer of the heart. So now, there's our heart, pericardium's open, but now we're just going to look at the sac the heart is sitting in. The interesting thing about the pericardium is it's very firm. It's very inelastic. It does not want to move. So the pericardium it's actually a space inside the chest before the heart even develops, and the heart kind of expands into it, like the heart's blowing a bubble, but the bubble is the heart itself going into the pericardium, and in the process it gets covered by a layer of the pericardium. Because of that, since the heart entered this space, there's some little blind alleys that we can use for surgical landmarks. And the first one is called the transverse pericardial sinus, and it's signified by this arrow here. The outflow tracts of the heart are always above it or anterior to it, and the inflow veins are always posterior or inferior to it. So you can actually locate with this transverse pericardial sinus, you can stick your finger into it surgically and isolate the outflow tracts from the inflow tracts. Likewise, if you kind of stick your hand underneath the apex of the heart and kind of let it roll posteriorly, you'll reach a point where your fingers can't go any further. That's called the oblique pericardial sinus. And if you do this and your hand is kind of cupping the heart as you do so, visualize your right hand cupping the heart and poking your fingers as high up as you can. Your fingertips are resting here at where the left atrium is going to be located. Now the layer of the heart itself is kind of interesting in that the parietal pericardium has a fibrous outer layer, and then there's a serous pericardium that's lining the inside of it. Serous means that it releases a watery fluid, and that watery fluid, there's not a whole lot of it in there, but it's also going to bathe the heart just a bit. Not bathe it in terms of submerging it, but there's just a little bit of fluid there to keep the heart's motion lubricated inside the pericardium. The fibrous layer on the outside, however, is very rigid. It's very inelastic, and the heart sits within that inelastic sac. The heart's outer layer, that epicardium, has its own serous layer, so it's secreting fluid as well. Now, if the heart and pericardium are both happy, no real problems occur. But if you get irritation or inflammation, you can wind up with a rub, and you can hear that on a stethoscope where the heart kind of slides harshly across the pericardium, and that's going to be a sign that the serous layer is not up to the job of keeping things lubricated at that time and place. A bigger concern happens when you have fluid inside the pericardium. Since fluid gathering in any real significant volume is inside an inelastic sac, it can't expand out. So that fluid, as it builds in there, could be lymphatic fluid, could be blood, could be inflammatory fluid released from the serous layer of the parietal pericardium or from the epicardium. If you get too much fluid in there, it's then going to compress the heart. And if the heart is compressed, it can't relax fully during the ventricles can't relax fully during diastole, and so we wind up compressing it, and the heart gets less and less efficient, less and less able to contract over time. This is called cardiac tamponade, and it can happen when there's blood, lymph, or other kind of serous fluid building up in here, and it's a very, very pronounced medical emergency. So it can't pump efficiently. It's going to get weaker and weaker. The pulses get weaker and weaker. Blood pressure drops as we go, and you can identify it by what's known as Beck's triad. Low blood pressure, because the heart can't pump efficiently, weak heart and valve sounds because it's unable to expand out, and jugulovenous distension. If the heart can't move blood through it, that blood backs up into the superior and inferior vena cava, and you might notice the jugular veins bulging out on the side of the person's neck. So know the signs of Beck's triad. All right, let's do a few questions. So go ahead and pause for a moment, digest the question. All right, what do we think? It's tunica media, E. So, do the other layers fail when we have an aneurysm? Sure, but it's the tunica media that provides the majority of the resistance against that pressure, the elastic fibers within the big vessels that may be able to resist that expansion and contraction. So tunica media is what mechanically fails when we have an aneurysm. All right, go ahead and pause, take a moment. So we have fluid surrounding the heart, so cardiac tamponade. Where are you going to find the fluid between those two layers? Well, the parietal pericardium is that outer layer of the heart that contains both a fibrous and a serous layer. The visceral pericardium is another term that you're going to hear for the epicardium. So I'm giving you a little bit of teaching with this question in that the visceral pericardium and epicardium are actually the same thing. Now, it can't be pleura. Pleura is lungs. We're going to get to them in a minute. Fibrous and serous pericardium, those two layers are adherent to each other, so they can't be involved. Endocardium and myocardium. No, you don't get any fluid there. That'd be inside the actual heart itself, as with the epicardium and myocardium. So once again, A is the correct answer here, and I'll see you guys at the next lecture.